Today we're going to talk about different applications of in-house osmolality testing. So first we're going to talk about what osmolality testing is. Then we're going to go through a few really specific common examples after taking a broad overlook at all the different ways osmolality are used in practice. And then I'm going to give you a peek at an up-and-coming application that's really promising, that's pretty novel, and it's been applied in practice by some pretty key players out there in the laboratory space. So super excited to shed some light on that as well. I'm super excited to be able to share more information on that in the coming months after some progress has been made on further solidifying that in publication. That said, I just want to briefly introduce myself. So my name is John Flasher. I'm a senior clinical product manager here at Advanced Instruments, directly responsible for anything clinical chemistry and microbiology. A little bit about my background. I'm a medical laboratory scientist by trade. I spent my years on the bench down in Orlando at Orlando Medical Center as a microbiology technologist, and like a lot of us do, I work the weekends at Oviedo Medical Center in Oviedo, Florida, as a generalist, so pretty much doing everything except microbiology. So in my time in the laboratory, I had the opportunity to use both the microbiology equipment that Advanced Instruments manufactures and sells to different laboratory customers, as well as the osmometers in the clinical chemistry space also. So a lot of familiarity and experience with what we're about to talk about today. That said, let's answer this question first. So what is osmolality? When I was on the bench, I'd get this ordered. Sometimes folks would order an Osmolal Gap. I would just, run the QC, run the test, report the result. I had a really great education. I'm not poo-pooing them, but osmolality is not something we really talked a lot about. So what is osmolality? So osmolality is the measurement of dissolved particles in serum, plasma, or urine. Some folks like to measure some other body fluids and things like that as well, but what we're going to be focused on today is serum, plasma, and urine, and it's measured in milliosmoles per kilogram of water. So it's really the concentration of dissolved solids relative to the volume of water in the sample or in the patient. So these dissolved particles can include things like sodium, glucose, and urea. In fact, when you calculate it off your chemistry analyzer, it's taking those three analytes into consideration in the formula. And they may also include things like ethyl alcohol. So another test you can run on your chemistry analyzer. Mannitol, which is a therapeutic agent used to alleviate intracranial and intraocular pressure after surgeries. Diethylene glycol, isopropanol, and methicol, which are all toxic alcohols, right, that we shouldn't be putting in our body, but sometimes they end up there, unfortunately. What is a normal serum and plasma osmolality? It's around 290 milliosmoles. So if you've used our osmometers in practice over the years, you know that the standard you run for QC every single day is the Clinitrol 290. This is why, because this is right around what should be considered normal. And taking that into account, we've also applied that to some of our other matrix-based standards like protanol and renal, where you'll see a broader range applied because clinically speaking, in children or adults, a normal range is usually somewhere between 275 and 295. So it's a broad range that we can expect and consider normal. And it's a little higher in patients above the age of 60. Urine's a little different. We use urine osmolality measurements in a bunch of different ways. And because it's measuring really how effectively your kidneys are concentrating the urine, as well as things like hydration and a number of other things that it can be used for, that range can be a lot broader. So it really depends on how you're using it. So really anywhere between at random 50 to all the way up to 1200 milliosmoles per kilogram of water. And here at Advanced Instruments, our osmometers can measure all the way up to 2000 milliosmoles. So well within the limits of what you might see in clinical practice there. So really high level example of osmolality down here on the bottom. Over on the left, we have a sample that was taken from a patient who is overhydrated. And over here on the right, we have a sample that was taken from a patient who is dehydrated. So we've got two beakers on either end. We have a beaker in the middle. That's a fun joke if you like the Muppets. But I like to include that picture there because when I was searching for pictures of beakers, that was the first thing that popped up, brought back some nostalgia for me. So in each of these beakers, we have the same exact number of dissolved particles, so the same number of little black dots, and we have a different volume of water. So on the left, because the concentration of those dissolved particles relative to the volume of water, because there's a higher volume of water, we'll actually see the osmolality go down. And on the right, because the volume of water relative to that same number of dissolved particles is lower, we see the osmolality go up. So dehydrated, osmolality up; overhydrated, osmolality down. So a really basic example. Another example that you could kind of use to mull over what osmolality is, or what it's a measurement of, is especially if you live somewhere in the north where it snows, where we get a lot of ice, right? We usually throw ice down on the sidewalk to change the freezing point, which is what we're actually measuring in our osmometers, because dissolving that salt into the water will actually change the boiling point. So it can kind of give you an idea of how we're able to use the freezing point to determine what the osmolality is based on the concentration of dissolved solids relative to the amount of water in the sample. And that leads us to our next topic. So our osmometers here at Advanced Instruments use a gold standard methodology for measuring the osmolality called freezing point depression. It's important to know what that is because there's some other osmometers out there that use things like vapor pressure that don't account for volatiles like ethyl alcohol and things like that. Freezing point depression really is the way to go for clinical applications because it does take into account those volatiles that can be present in the patient's sample, like ethyl alcohol, like toxic alcohols, like diethylene glycol, like mannitol, things like that. So when these solutes or particles are dissolved in a solvent, in this case, we're going to use the example of water, the freezing point of that solution is lowered compared to that of the solvent alone, right? Going back to the example of throwing ice down on the sidewalk so we don't slip and fall in the winters here in Massachusetts where we're based. As more solute is introduced, the freezing point decreases even further. And by measuring the freezing point of the solution, the osmolality can be determined. So how it works, if you're looking at the curve here on the bottom left part of the screen, is we cool the sample down really fast, super cool it, way past the freezing point. And then we initiate that freezing through some sort of stimulus. This process is called nucleation. If you have one of our older osmometers, you'll actually hear a click-clack of the solenoid that actually initiates this process. If you put a bottle of water in the freezer and make it really cold really fast, doesn't freeze right away. If you take it out and bang it on the table, you can kind of see this property in action. Similar approach that we're taking here to freezing the sample within the instrument. After nucleation is performed, we'll actually see that freezing point plateau. And once it plateaus, that's when we can take the most accurate measurement, and that's how we're able to determine the osmolality based on the variation of the freezing point in the sample. So that's how these osmometers work. So what is osmolality used for then? So we know what it is. We know how the instruments measure it. So why the heck are the physicians ordering this thing? So it's used for really a bunch of different reasons. We have a long list over here on the slide. Primarily, it's used in nephrology for electrolyte disorders. The most common is hyponatremia. It actually differentiates between true hyponatremia and pseudohyponatremia. We'll get into that example, I think, in the next couple slides here. And a number of other things in the nephrology practice as well. In emergency medicine, it's primarily used for alcohol intoxication and toxic alcohol ingestion. So folks who have had way too much to drink, or also folks who may have accidentally or purposefully drank a toxic alcohol. Like when we talked about before, diethylene glycol, isopropanol, methanol, something like that. These things do happen. It's used in the pharmacy as a QC tool. So if you're preparing an infusible, if you prepare it correctly, it should have the same exact osmolality every time, right? If your osmolality is different after an infusible is prepared, then it's likely that it was prepared incorrectly and won't have the desired effect. So it can be used as a QC tool in pharmacy as well. In surgery and critical care, it's also a helpful tool for hypovolemic shock prevention and therapeutic drug monitoring. So I talked about mannitol as a tool for relief of intracranial or intraocular pressure. And then in internal medicine and endocrinology. So the example that we're going to be taking a deeper dive into on this list of 5 down here is diabetes insipidus. It is a critical tool in the diagnosis of diabetes insipidus. If you don't have it, that is osmolality, in-house in your laboratory, it's very difficult to make this diagnosis. And you're going to see why once I go through the process. It's a very critical tool. But at the end of the day, in summary, osmolality really helps narrow the list of differential diagnoses from 100 to a few dozen, right? So not necessarily a diagnostic tool, but an extremely useful tool in helping you narrow your diagnoses so that you can use other tests in the laboratory to further narrow that down and confirm your suspicions. And that's straight from the words of a nephrologist. You don't have to take my word for it. Okay, so of all those things we just covered, the first thing that we're going to talk about today is hyponatremia. Hypo, low, natremia, sodium, low sodium. So how osmolality is used in the assessment and management of hyponatremia is kind of captured in this big cascade here on the slide. So hyponatremia, as I had mentioned before, low sodium concentration in the blood. Why is this important? Well, we see it a lot in patients who are in the hospital. So 22% of patients in geriatric hospital wards will suffer from hyponatremia at some point in their stay. 6% in non-geriatric wards, so not as common, but in the ICU where there's a lot going on with these patients and the management of these patients, 17.2% will commonly experience that. That's right from a paper reference down there at the bottom. Serum osmolality measurement is a critical tool for determining hyponatremia, real hyponatremia, from pseudohyponatremia, quote unquote, fake hyponatremia. So that's captured in the first part of the cascade here. Once you get your low sodium result, which is at the top of the cascade here, this one is measuring 135, you're going to take a serum osmolality measurement. If that serum osmolality measurement is less than 280, then it's likely that you do have low sodium, right? If the concentration of dissolved sodium in the blood is lower, then your osmolality should be lower. But if you measure your osmolality and it's not lower, then you likely have to look at some other potential factors that could influence pseudohyponatremia being the cause of your low sodium, right? Different things that can actually influence the sodium concentration in the patient's blood, like hyperlipidemia or secondary to different medications, like Gleevec, for example. So there are a number of different things that can influence that sodium level. Okay, so let's say we confirm that this is the real deal. This patient actually has hyponatremia using that serum osmolality test. Once we get past that result, we move down to the next step in this cascade, which is testing the urine osmolality result. And this is going to help you determine the level of water excretion relative to that sodium value. So if the water excretion is normal in your patient, you're going to see your urine osmolality be less than 100. If it is greater than 100, then you know your patient has impaired water excretion. And based on the urine sodium result, you can then cascade down to a number of different treatment options. So the result of your osmolality test can lead you to decisions that can be the difference in treatment of providing fluid or withholding fluid from your patient. So it's a really important tool at kind of cascading down to how the treatment decisions are going to be carried out for your patients. And it's a tool that can really be the difference between appropriate care or inappropriate care, which, as we know in the clinical space, can be the difference of, you know, your patient feeling better and improving or not, which could be the difference of maybe your patient leaving and having, you know, a positive life experience, or continuing to deal with some of their ailments and maybe being readmitted. So it's a really important tool. We have a couple good examples of that in practice as well. Okay, the next example that we're going to cover today is toxic alcohol ingestion. So again, this isn't the alcohol that we drink when we go down to, I don't know, Harpoon in Boston to have a couple beers. These are things like antifreeze or isopropyl alcohol, brake fluid, or methanol, which is represented by the clear bottle over there. So typically, when we suspect that a patient has ingested one of these things, what the physician will order is the Osmolal Gap to determine whether or not a patient has ingested a toxic alcohol. So what is that? That's represented over here on the left. So over here on the left, you'll see these two little chunky kind of bar graph looking things. All the way on the left side, you'll see the calculated osmolality, and I'd mentioned that before. That's going to leverage the formula that you see just above that bar graph using the sodium, blood urea nitrogen, and glucose results, and if you have it, the ethyl alcohol result as well, to basically calculate what the osmolality is. You're going to get those right off your chemistry analyzer. What those are going to miss is that pink square on the top of the right bar where it says measured OSM or measured osmolality. So that gap between the measured osmolality and the calculated osmolality is going to give the physician some clues into whether or not the patient did potentially ingest a toxic alcohol based on how the patient presents and other information you gather from the patient and their family. So it is a really important tool in determining the level of risk that your patient has of having ingested this toxic alcohol. And it's really important. So this data is a little bit old, but back in 2018, the US National Poison Data System actually reported 7,242 cases of ethylene glycol alone. That's just here in the US. 7,242 cases, 1,607 cases of methanol exposure. So it's a lot more common than we maybe like to see. So this is a really important tool. And if you're in the laboratory, unlike ethyl alcohol, there's really no way to directly measure the concentration of one of these toxic alcohols in the blood without sending it out to a reference lab to have specialized testing performed on it. And as you know, if a patient ingests one of these toxic alcohols, you don't have time to wait for that result. That could take days, right? You need to act in minutes, because if a patient did ingest a toxic alcohol, that could mean risk to their organs, so permanent organ damage or organ failure, and potentially even death. So it is a high risk to the patient if you don't get this information out to your provider right away and make sure you're making the appropriate treatment decisions to keep them away from having to suffer some of these morbidities. All right. So the next example that we're going to use as part of this webinar today is diabetes insipidus. So diabetes insipidus is a water clearance disorder. It's a disorder that presents itself with the inability to concentrate urine, more or less. So how we're actually going to identify if a patient has the inability to concentrate urine is we're basically going to put them through what's called a water deprivation test. And it simply isn't possible without an osmometer. And I'm going to explain to you why in just a few seconds. So to kick off the water deprivation test, the patient is going to come into the hospital. This usually starts early in the morning, around 8 a.m. They're going to empty their bladder. They're going to record the volume of urine that came from them emptying their bladder. They're going to send it up for a urine osmolality test, and then they're going to draw the patient's blood, send that up for a serum osmolality test. At this time, they're also going to record the patient's weight. Okay, and then for the next 8 hours, every single hour, they're going to measure the patient's weight again, and they're going to take a urine sample again. Every single hour, they're going to take that urine sample and measure the urine osmolality. Every 2 hours, they're going to draw another blood sample from the patient and send that up for a serum osmolality test. Why this is really important, both the serum osmolality test and the weight measurement during this time, is because if the weight loss of the patient exceeds more than 3%, which means during the water deprivation test you've dehydrated yourself so severely that you've lost 3% of your body weight, or if the serum osmolality exceeds 300 milliosmoles per kilogram, then it's determined that we can no longer continue the test without putting the patient in danger. So we have to stop right away. So if you don't have osmolality testing in-house, forget about it. You can't perform this because there's no way for you to assess the risk to the patient during the 8-hour process of performing the water deprivation test. So it's really important that you have quick access to those results throughout this entire 8-hour period. Okay, so after 8 hours, if the urine osmolality at any point in the process is and maintains a result of greater than 600 milliosmoles per kilogram, that means you have a high concentration of dissolved particles in your urine relative to the amount of water, which means your kidneys are concentrating your urine just fine. So you likely don't have diabetes insipidus. So they would go ahead and rule that out. They would terminate the test, and then they would move on to other potential investigations to try to inform some other diagnosis for whatever symptoms you had that led to them performing this test. However, if your osmolality, your urine osmolality result stays below 600 milliosmoles per kilogram, then they're going to continue the water deprivation test after providing you with a drug called desmopressin. So desmopressin, it's an analog of the antidiuretic hormone, which your body naturally makes in response to dehydration. So if you have a natural response to what is an analog of antidiuretic hormone, that should trigger your kidney to then concentrate urine. So after providing the desmopressin, we're going to go ahead and measure the urine osmolality hourly for the next 4 hours. And it's okay after this, the patient's allowed to eat and drink freely. They've waited a really long time. 8 hours is a long time to not eat or drink anything. At this point, they can go ahead and pick up the glass and have a couple swigs of water. After providing the desmopressin for the next 4 hours, if there's no increase in that urine osmolality, then you know even in response to that antidiuretic hormone analog, there's no increase in your body's ability, or really your kidney's ability, to concentrate that urine. So then we know the diabetes insipidus that we identified from the first part of this test is nephrogenic in origin, which means it can be caused by a number of things that we've listed there on the right: chronic renal disease, different drugs the patient might be on, hypercalcemia, hypokalemia, things like that. Down here on the bottom part, if the urine osmolality does increase in response to providing the patient with desmopressin, then we know that the kidneys are working just fine. They're doing their job. So then we can determine that this is a central diabetes insipidus. So this can be idiopathic, or it can be caused by a number of other things secondary to what the provider might be seeing in the patient at this time as well. So without this tool, you can't provide 8 hours of testing, so 8 urine osmolality tests, 4 serum osmolality tests. You can't rule out the risk of your patient becoming severely dehydrated at any point in that 8-hour period. And you can't measure the patient's response to desmopressin, which again is that analog to the antidiuretic hormone. So you need osmolality testing to perform this diagnosis. So it's a really, really important tool for patients who may be suffering from diabetes insipidus, and for those providers who want to use it to diagnose them. All right. So I'm going to move on to our last example as part of the presentation today. I know we only have about 5 minutes left. I tend to ramble, and that is assessing abnormal proteinuria. So proteinuria is protein in the urine, and proteinuria can be secondary to a number of different conditions of the kidney. It could be, secondary to kidney damage or chronic kidney disease, and a number of other things that could be going on for your kidneys to allow larger proteins, larger molecules to get through and get passed on to the urine. It's not doing what it's supposed to be doing in there, right? So it's really important in the differential diagnosis of various renal disease and the assessment of the prognosis in response to therapy. So what do they have? How are they doing? How severe is it? And how are they responding to therapy? So it's a really important tool for all of those things when we're assessing our patients' severity of kidney disease, more or less. So there's a number of different ways that we measure proteinuria. There's quantitative measurements of proteinuria. We can use dipstick or sulfosalicylic acid, which are manual methods, right? I think we've all used urine dipsticks where we're holding the container that the dipstick came in up to the strip that we put in the urine, and is that green? Is that blue? I don't know. So not super reliable. And then we can use a tool called protein creatinine ratio, where we actually take a random protein concentration and the creatinine concentration, use that ratio as a predictor of the 24-hour protein excretion test. Unfortunately, all 4 of these methods have poor correlation with that 24-hour protein excretion test, and that's because of a number of different factors. The first is the amount of protein excreted is independent of the volume of urine. So you can have a high volume of urine and varying levels of protein excretion, which can skew the results that you're getting at any point in time with these random protein measurements. There's variability in protein excretions with patient activity or even position. Are they laying down? Are they sitting up? Are they standing up? Were they walking around all day? That can all influence the level of proteinuria in the patient. The qualitative methods are prone to observer error. I just gave you the example of, is it blue, is it green on the dipstick? And then accidental contamination is an issue as well, right? We want to measure the protein that's coming out through the kidneys into the urine, and we don't want to catch anything else that could go in there like blood or semen or vaginal discharge that could otherwise influence the protein concentration result. So what can we use instead? So this chart over here is actually a graph taken right out of a paper that was published way back in 1993, which is why in the beginning of the presentation I emphasized the need for some fresher eyes on this and some newer publications. But what we can use is the protein osmolality ratio. So this is the strongest predictor of the 24-hour 24-hour urinary protein output. So in a patient with a normal urine protein osmolality ratio, if that is less than 0.12, then we know that the level of proteinuria in the patient is normal without waiting the full 24 hours to actually collect the urine from the patient. So imagine, a pediatric patient trying to be there every time they urinate to collect all of the urine that they excrete over a 24-hour period of time. Or really just imagine any patient. That's a tall order for folks who are juggling multiple patients on the floor in the ICU or in the geriatric ward for them to make sure they're there to collect all of this urine over a 24-hour period. So it's important to use tools like this. Again, we also don't want to have to wait 24 hours, right? So if we can send a sample up and get a result in a couple hours, in an hour, however long it takes for your laboratory to turn around routine testing, that's going to save us a lot of time and effort around assessing the patient's level of proteinuria. So again, if that protein osmolality ratio is less than 0.12, then we know that the level of proteinuria is normal, or the protein excretion is normal, with a pretty high sensitivity and specificity. And then if that urinary protein osmolality ratio is greater than 2.5, that indicates a level of more than 3 grams per 24 hours of protein output in the urine. So that correlates to, if we were to actually collect that urine for 24 hours with high confidence, 91% sensitivity and 98% specificity, that patient has an abnormal level of proteinuria. And you can kind of use a sliding scale to determine what the risk of or what the level of proteinuria in that patient is. So this is also a really helpful tool in making that assessment much quicker, right? Within an hour or two, as opposed to waiting a full 24 hours when you would have to, collect all of that patient's urine over the period of an entire day leading up to performing that testing. So it can save you a lot of time and effort. And there are some sites who are actually using this. In fact, I know that the folks over at the Mayo Clinic have been putting this testing methodology in practice for quite some time now. And they run this on the majority of the urine specimens that come through the laboratory, the urine osmolality test that is, so they can have this result at the ready if they need to calculate the urine protein or the urine protein osmolality ratio to make the assessment of what this patient's 24-hour protein excretion might be. So that is how they use that tool. All right, I'll stop talking now. We're right at time. If you want to make these freezing point depression measurements readily in your laboratory and turn these results around quickly, then you need to use one of these tools, right? The Osmo 1 is our single sample osmometer. The Osmo Pro is our mid-throughput multi-sample osmometer. And our newest osmometer is our Osmo Pro Max. Allows you to run up to 500 tests uninterrupted using this 20-position turntable that you can freely remove and add almost any primary sample tube or urine tube onto to automatically run the tests. So no more pipetting, no more using the sampler and the Osmo 1 to load it up into the solenoid. Makes things a lot easier. So these are really cool tools. If you're interested in leveraging any of these tools to support the applications that we talked about at the beginning of the presentation, feel free to reach out to me and I can point you in the right direction, connect you with a sales rep or someone else who you might want to talk to explore more information about some of the details around these applications or more information about these instruments or this methodology in general. With that said, that concludes the presentation for today. I know we're right at time, but if anybody has any questions that I can answer, I'd be happy to do that.